Good morning, everyone. Let's start with the sessions on day 2. I would like to invite Dr. Brahmajit Singh, who is a consultant medical oncology, hemato-oncology at Pace Hospital, Hyderabad.
Good morning, ladies and gentlemen. Before I start today's presentation, I'd like to thank Roche for this opportunity, plus choosing this beautiful venue. So I'm going to talk about designing research protocols in breast cancer. So do you see this map? What do you see in this map? There's pink everywhere. Pink means the incidence of breast cancer is increasing everywhere. Everywhere there is a pink color. But what intrigues me is that the mortality rate in breast cancer still continues to be the highest in the world. Why? Why is the mortality rate of breast cancer so high? That means something is wrong. Yes, this is increasing, but why a high mortality? Breast is an external organ. We can diagnose in stage 1, 2, okay, metastatic, yes, but still a very high mortality. So what does it actually mean? It means that our armamentarium, our desire, our will, our strength is not sufficient to fight this cancer. So the need of the hour is we need more drugs. We need better drugs to prevent death. The problem is that the development of a new drug requires a major investment of capital resources, human resources, and technological expertise. So when you see a trial, actually it involves 2 phases, a preclinical phase and a clinical phase. In the preclinical phase, animals are tested, takes around 4 to 5 years, and then a clinical trial, phase 1, phase 2, phase 3, FDA gets approval, and phase 4. So what actually happens is that around 10,000 compounds are tested in the first phase. In the preclinical development, only 250 make it up. And by the time we come for clinical development, around 5 compounds. So from 10,000 molecules, finally we get an approval of only 1 drug. And if you see the time span, 3 to 6 years, preclinical, 6 to 7 years in phase 1, phase 2, phase 3. And finally, when we get a compound, when we get a phase 3 and phase 4 trials, it's another 2 years. So the molecule we are talking, any molecule we talk today is actually a 10-year-old molecule. How many patients of any cancer, forget about breast cancer, will survive for 10 years waiting for a new drug? So the basic requirement that we have is we need to shorten this. And that is what I am going to tell you about. Now the problem is who pays for it all? The patient pays for it all because he has to wait. We as doctors have to wait. The government and the companies who are making these drugs, they all have to pay for this. Can we do something about it? Is it possible that can we shorten this period? Because legally speaking, phase 1, phase 2 and phase 3 trials are an essential component of this drug. And we cannot do accelerated approval for every drug. So yes, we can. Now the point is, traditional clinical trials designs such as phase 1 and 4 trials have been in place for decades. So what has happened now is that with scientific and technological advancements, we are innovating new clinical trial designs. I'll give you an example. I start with something called seamless designs. Now what does seamless mean? I'll be going a bit fast. Seamless means that there is no discrimination between phase 1, phase 2 and phase 3. We have combined all the 3 trials together. So it's a continuous process. Usually what happens is we have a learning phase and then we have a confirming phase. So what happens is when we combine these phases, we decrease the time period and we get better results. So what actually will happen means seamless phase 1 and 2 designs simultaneously we assess toxicity and efficiency, while seamless phase 2 and 3 designs combine the explorative and confirmatory stages. Therefore, you accelerate the development timeline. You reduce the timeline from 10 to 15 years to 5 to 6 years, reduce the total sample size, and better estimate the risk factors of the adverse events. So that was one. Now, another thing that has been devised is the master protocol designs. Basically, it means that we have one concrete design on which we work up with the other trials. So it's basically sharing, and there are 3 types: basket, umbrella, and platform trials. You know what? I'll be going a bit fast. Basket trial is to study one therapy across multiple diseases. So it's a basket. The basket is the drug. You keep adding. HER2 is a basket. You add breast, you add stomach, you add colon, you add everything. and then you see which one it works. So basically, one drug, multiple diseases. The reverse, the umbrella trial. Study multiple therapies within one disease molecular profiling. Okay? And then there's a platform design to study multiple targeted therapies in the context of a single disease in a perpetual manner. As I told you about basket trial, this is what an umbrella trial looks like, and this is what a platform design looks like. But what I want to tell you is most important, that is shaking the technological part, the statistical part, is the adaptive clinical trials. What do you see here? Dinosaurs, they became extinct. Why? Because they never adapted. If we humans have to survive, we have to learn to adapt. And that is the concept of this trial. So allows for the pre-planned modification. When you do an RCT, RCT is concrete inclusion criteria, exclusion criteria. This is the number of patients I need, strength of the study. Everything is defined. We do not assess until unless the trial is over. But what if we assess at every level and we adapt according to our findings? And that is the concept of adaptive trials. So modifications may include terminating a trial before completion due to futility or efficacy, re-estimating the needed sample size to ensure adequate power, enriching the target population enrolled in the study. Enriching means using that population which has high risk, selecting across multiple treatment arms, revising allocation ratios used for randomization, or selecting the most appropriate treatment. So what actually you want to show you is that a traditional has a fixed sample design. You have a design, conduct, analyze. In adaptive, you design, you conduct, and you review, and you assess, go back again adapt, and then you get your analysis. So there are different types of adaptive trial designs. We have adaptive group sequential design, adapting sample size, adaptive enrichment, biomarker adaptive, adaptation to treatment arm selection, adaptive randomization, adapting endpoint selection, adaptive multiple features, and smart designs. Actually, I'll be going, as I said, there's no time, so I'll be going in brief. So group sequential designs, what does it mean? Group sequential designs allow for prospectively planned interim analysis and possible early stopping due to efficacy, futility, or harm. These stopping rules may be binding or non-binding. That means you can stop a trial in between. So the advantages, trial can stop early, reducing overall sample size. Results can be disseminated more quickly if trial stops early. So the challenges are there. Now another thing now is, suppose you have the capacity to adapt the sample size. The biggest problem happens with rare cancers. The sample size becomes an issue, or very common cancers, but not in that particular geographic area. So here you adapt the sample size. When uncertainty exists around the estimates used to power a study, an interim analysis can use accumulating data to re-estimate the sample size to ensure a trial has high power if the true magnitude was less than hypothesized, but is still clinically meaningful. Okay, so what are the advantages? You reduce chances of a negative trial with a meaningful effect by increasing the sample size to have sufficient power. Blinded approaches and re-estimation of nuisance parameters minimally impact type 1 error rates. So the another concept now is adaptive enrichment. Now what is that? In trials where it is believed that a subgroup of the population will experience more benefit from an intervention like our HER2 breast cancer, an adaptive enrichment design provides the ability to drop lower performing subgroups at an interim analysis. Because what will happen is we have 100 patients, 50 are not responding, 50 are responding. When you study the overall analysis, you say, okay, 50% drug is working. So you remove those 50 who is not responding, and your study sample becomes only 50. So that study resources are more efficiently allocated to those with a greater chance of benefit. So see, adaptive enrichment has two concepts: prognostic designs and predictive designs. So advantages, you can refine eligibility criteria to enroll subgroups most likely to benefit from the intervention. Approaches exist for both prognostic and predictive. Okay. So examining for the breast cancer trials, Embarca and Olympia are examples of enrichment design. So we have something called biomarker adaptive. Biomarker adaptive is a subgroup of enrichment design. Okay. So this method allows adaptations of trial designs based on interim analysis of treatment responses or biomarkers such as genomic markers. So SOLAR 1 was a phase 3 trial based on this. Advantages and challenges. Now there's something called, if you can adapt the treatment arm selection, which is not actually possible in an RCT. So what do you do in this? adaptations to modify the study design to allow for adding or dropping treatment arms. Modification to a trial design that could add or terminate study arms present in both early phase studies, example dose finding, and later phase studies, example seamless designs and platform trials. So the advantages are, some examples are adaptive dose finding, drop the losers, adaptive seamless, and adaptive platform designs. Okay, so what are the advantages? Extremely flexible to terminate study arms for futility or efficacy and add new arms. So your trial gets absolutely modified. Shared control arm, if used, may increase allocation to study interventions, can use a single master protocol versus multiple standalone trials. There are a lot of challenges. So now something called adaptive randomization, something which you can't even think of today, because the concept of randomization is you're removing bias. So randomization is the fundamental basis for establishing efficacy of an investigational treatment in an RCT. In theory, the randomness element seeks to establish study arms with similar patient characteristics between arms such that the only differing factor is the treatment assignment. So there are several adaptations. The most simple is a coin flick, but it had problems, so we used stratified block randomization. However, because that also had stratified block randomization also has a lot of issues, we have incorporated multiple methods of randomization, but suppose we can do an adaptation in that to address the limitations of stratified block randomization. Covariate adaptive designs and response adaptive designs are now being used. Covariate means we're created to marginally balance multiple covariates at once rather than achieve balance within each stratum, and a response adaptive design which modifies the allocation ratios based on the accumulating evidence of success in the trial arms. A lot of advantages, a lot of challenges. Now, endpoint selection. This is where most of our trials face the Waterloo. We plan for overall survival, we don't get overall survival, but we get PFS benefit. But since our main endpoint was OS, the trials become a negative trial. So if we can adapt the endpoint selection, the number of negative trials will definitely come down. So the endpoint selection, the critical part of designing a clinical trial. Now the problem with this trial is, I'm sorry, I'm going a bit fast. The advantage is that we can select a primary endpoint while the trial is ongoing based on uncertainty in the design stage. Recent statistical research explores new designs to incorporate this adaptation, but there's a big problem. It has not been recommended by the EMA, that is the European Medical Association. Even FDA has a lot of questions on this. So they have recommended review and discussion with regulatory authorities. This is the one point, endpoint adaptive, is still a lot of issues with this. So now what we do? Khichdi. You know what a khichdi is? You mix everything. So when you go for, before I joined the army, we used to have in a bowl, curd, rice, your dal, everything was separate. But when I joined the army, time was at premium. So what do? Put the rice, turn the curd in it, put the dal in it, put the sabji in it, and mix everything. So this is the concept of adaptive multiple features. So you adapt everything, and then you continue to have a trial. Now this has a lot of issues because that means it's not a trial, it's not an RCT any longer, but yes, the benefit of this would be phenomenal. So a clinical trial may also include multiple adaptive design features. As with any single trial design feature, it's important to ensure that the trial operating characteristics maintain the desired type 1 error and statistical power while enrolling a realistic sample size across a range of plausible future scenarios. Advantages: greatest flexibility by combining multiple adaptive features, which I mentioned before, may result in designs with greater appeal to participants. Challenges, obviously, they will be there. Now, the latest one more concept which has come, this was a part of an adaptive trial. It's called a SMART designs. What does it stand for? Sequential Multiple Assignment Randomized Trial. It's again an adaptive research design for building optimal adaptive interventions. The general framework of a SMART trial is every participant is randomized to an intervention arm initially, similar to the start of a classic fixed RCT. Following this initial assignment, patients move through a series of stages with the option to either stay on or switch intervention arms depending on the response in the intervention in the stage prior. So with the response, you can change the patient design. Okay. So it basically mimics standard clinical practice, and that with time, patients will be assigned to more effective treatments. Now, Therefore, you build an optimal dynamic treatment regimes and also permits researchers to identify characteristics of patients for whom a particular treatment regime may be most effective. So, to summarize, adaptive trials have a lot of advantages. Number one, improved flexibility. Number two, more efficient use of allocation of available resources, finance, the number of patients, the manual, the labor, everything included. Improved statistical efficacy, ethical considerations more readily addressed, ability to answer broader questions that may be refined as a trial progresses. Stakeholders, the companies which are sponsoring, which are putting the money, the governments, may be more willing to support studies with adaptive elements because of the added flexibility. Challenges, advanced and specific analytical methods needed to be avoid type 1 error, rate inflation, that is identifying an ineffective intervention as effective, that is type 1 error. Gains in efficacy generally represent a trade-off with other trial components. Logistics to ensure appropriate trial conduct and integrity. Adaptation may be limited by scientific or clinical constraints or to make interpretation more challenging. To summarize, innovations in clinical trial design started with changes have recently been made to in breast cancer also. The first change reflects the speed of research progress. So you speed it up, you shorten the time span by using seamless trials, phase 1, phase 2 combining, 2 and 3 combining. Now, after the seamless trials, the second change is breadth of research. So you are increasing the sample size, you are adaptive, using randomization, using everything possible. So you have now a wider breadth of research progress. And last but not the least, adaptive design trials. Thank you. The reason I put the dinosaurs is because we need to adapt before we become extinct. I finished. I hope I have not stretched the time.
Number one, it was a brilliant presentation that needs to be integrated in teaching the students because, you know, all the evidence, what we are using in clinical medicine is based on randomized trials. So if you would sit here with our friend from Roche, and I think he left already, but if you design or consider this is an investment of a huge amount of money for 10 years or even longer, not knowing exactly what the result will be. So in other words, you can burn a drug, yes or no. And this is number one. Number two is, you didn't mention that, designing the control group. So you can have every trial being in favor of something. If you have a weak control group, and what I really hate the most is if you take whatever, triple negative, or the inclusion criteria are all different. So you cannot compare stuff. The testings are different, the antibodies are different, just to avoid that the drugs from different manufacturers are comparable. And you've seen that with different scores for breast, lung cancer, and all that stuff. That is an assumption, and I guess it's working. So you have so many points to consider the right trial design, the right sample size. And you showed this with your dinosaurs. If you go back, we have done trials with the phase trial, for example, burning down 4,000 patients for the simple question, is the aromatase inhibition from AstraZeneca or Novartis better? So this is something which should never, ever happen again. 4,000 patients with the whole money for a bullshit question, you know? There was no difference whatsoever, but the companies, you know, at that time, they were just burning down their money. And there was a recent publication in, I think it was JAMA Oncology or Lancet Oncology just recently, showing that the amount of accelerated approval are withdrawn over time. And one of the problems is you have the withdrawal from the FDA, but still the EMEA label stands or the other way around. So a good example for that is Avastin, which is not used in the US, but it's used in first-line metastatic disease and colorectal cancer in Europe.
Yeah.
So there is, you know, there is no unique evidence, and then this is so important to understand what decided that and what are you really taking out of that. So it was a brilliant presentation. Thank you.
Thank you, sir. Thank you,
Excuse me,
sir.
sir. Good morning, sir.
Good morning.
Nice presentation. Clinical trial is a long question in our examinations. Every year or alternate it comes. Just few query. Uh, yeah, every clinical trial has a protocol. So we have to proceed according to protocol. But sometimes FDA provides accelerated approval for some drug. Is it not violation of the protocol, sir?
No, 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 no. See, the concept of accelerated approval is very different. The concept of accelerated approval is very different. The aim is when we have evidence that this drug is beneficial, then only the accelerated approval is given by the FDA. Now, you cannot wait for phase 3 trial to be over. See, because phase 3 trial means 5 to 6 years. You're going to wait for, that's what I said. What is your end point? Are you looking for overall survival or are you looking for PFS? So whenever there is a concept of accelerated approval, you're dealing with PFS, progression-free survival, not with overall survival, because overall survival will take 5 years. Now you can't keep a patient waiting for 5, he may not survive that long. Okay, so the immediate need of the patient has to be met. So we have a PFS benefit. Probably in the next 3 to 4 years, if he survives, there will be overall survival benefit. That is why accelerated approval is given. Okay, there's a lot of good data on this on the net. You can go through the FDA site also. What is accelerated approval? What is life-saving drugs? Very good, very well detailed decision is given, and it's very scientific. It's very, very, very scientific. Okay. Anything, sir?
I think the iSpy 2 is one of the classic examples of, multiple adaptive trials, all running so many drugs with so many markers.
Sir.
Brilliant. I'm sure people like Dr. Christian Jackies are involved in the design of such brilliant protocols. And
Trial. The iSpy trial is so complicated that people have a hard time to understand what's going on there. But this is one of the best trial designs I've ever seen, that you are designing, picking the best while you're on the flight. And that needs a tremendous logistic team, in the US to get this really done, that you don't recruit patients in the wrong group. But that's the only way. And you have to have a distinct question. And it's like your meal in the army, You have just one question what you're going to answer. So you cannot answer 2 or 3 questions. You don't have the power in that. It doesn't work.
Thank you, sir. Any more questions? Thank you, sir.
Thank you, sir. Now I would like to invite Dr. Christian Jackish for our next session, please. Thank you.
Okay, so I'm just catching up with the issue, learnings from clinical research in early breast cancer. And just to echo the question that has been asked previously, do you have the remote control? There is no? Because you're leaving so quickly, I was considering that you have the remote control. This is the one? This is the one. This is one, yeah. Okay, good. This one. Okay, good. So in HER2 positive breast cancer, the whole story would be dead if that would not be a biomarker adapted treatment. So there are data. No, I'm fine. No, it's okay. There are data out there that the curves are just exactly the same, superimposable when you do not test it. So my agenda is written here, 3 points I would like to share with you. You know this from yesterday. So I hope you can read it. So where are we and where are we coming from? Like the dinosaurs we just saw in the last presentation, we still have classical histopathologist features. We have conventional predictive factors, and then we have adaptive new biomarkers. So for example, BRCA, it's not mostly a player in HER2 positive disease, but the gene expression profiling assays, as I mentioned this yesterday in the ADAPT trial in the APT trial from Sarah Tulane, is showing you that you have an assumption of a whole bucket, and this is not what biology was considering. We don't understand biology to this extent. So what we have to do is to really, from a research point of view, get samples. So in other words, you should be connected in clinical trials, not only for randomizing your patients for the treatment options. The golden nugget of all these trials are tissue and serum samples. And usually in trials where you have a translational research program, the adherence is up to 30 to 40%. So in other words, people do not understand why this is so extremely important. And if you just have a look at the HER2 pathway, it is not only the 4 subsegments at the extracellular domain or the TKI internal domain. We have gene mutations, gene amplification, and HER2 overexpression. But this is not simply matching over each other. It has totally different biological meanings. And we have to learn when to look for HER2 gene mutation, usually in progressive HER2 positive disease. You might have a mutation, and then you have to have, for example, naratinib and other drugs, and you would not be very successful if you continue pleasing the extracellular domain. So allow these 3 issues to bring to the brain of the doctors is a very, very, very hard issue. So let's start here from the beginning. It is totally important to understand that a normal cell has tons of HER2 receptors. And based on the malign transformation, you have these overexpression or gene amplification. So it's growing and growing and growing and growing. And this is what we translated in our vocabulary in bad prognosis. Until we identified that there must be a certain threshold to understand what a HER2 positive, a classical HER2 positive disease is. And that is not massaging the data, maybe is it that or that you have a ratio, a threshold, and if that's above, it's fine. If it's below, it's negative. And that is something what also has to be understood. And you have 2 issues here. This is the family are growth factors, and these growth factors have to be active. Even if you have them on your path slide, it doesn't work that it's active. I mean, you can have a bulb here in your hand and it's not working. This is the same thing. You have to have a functional test. And then when you have it, you would be much more happier if you have a drug that is working. So these are 2 issues. You have to have a biomarker, you have to have a biological meaning, and then you have to have a drug which is working and which is really working only in the designed population. And then if you then go back and consider that there are hetero and homodimers in the 4 members of the families, we only know so little. And it is so interesting that here there is no physiological ligand for HER2. Never has been. So nature was doing something what nobody needs until Dennis Lehman and Axel Ulrich identified the biologic meaning, and then following of that, the biological meaning. So HER2/neu is known as a ligand, and that HER3 has no intrinsic tyrosine kinase activity is another important issue. This is why you need pan-TKIs inhibitors. And then there's a totally different thing. I was mentioning yesterday, Charles Peru, luminal and HER2 enriched and triple negative subtypes. But also what we know is that there's a difference of prognosis in the various types. And then also there is an immunogenetic or immuno-oncologic environment. So we know that there are immune cold and immune hot areas. So it's quite a low-brainer that you consider that the luminal cancers are immune cold, so you cannot do anything there. But when it comes to the subgroups of HER2 enriched, non-luminal, whatever that is, you have to have other features like PAM50 to really identify that. And the triple negatives are like here in India, they are really hot, And there you have a totally different approach. So there are data, I'm not showing this today, that if you have an immune hot situation in HER2 positive disease, it was a retrospective analysis and of the American trial, you don't need that much anti-HER2 treatment. But these are speculations, these are subgroup analysis that has never been pre-planned, so nobody would buy that for routine working. So if you see those different subgroups concerning the environment for immune cold or hot, you have to understand that that is linked to the matrix of the tumor. So the stroma is something which is interacting with the tumor cells, and the immunogenetic cold or hotness is usually brought by the stromal and not by the tumor cell. So that's an interaction like in your family, you know. If one is fine, but if the whole family is coming together, there's an interaction which might end up on a pleasant weekend, and then after that, everybody's happy that they can go their own ways. And that's the same thing here in the breast cancer tissue. So you have to have a look on both the tumor environment and the stromal environment. And all these is translating in this very important piece of information, which is known by everyone, the prognostic difference if you don't treat. This is why we call that a negative prognostic marker with a high predictive of a drug that can be used. So this is prognosis and predictive factors are totally different. So now we come to the part of confusion. We have to understand that the definition of the classical HER2-positive disease is that you have immunohistochemistry 2+ or 3+ or 2+ and FISH-KISH positive. This is what we call HER2-positive disease in early breast cancer setting. That's the classic definition. But there you have the management of HER2-low and HER2-positive and HER2-negative, or maybe HER2 ultra-low or HER2-0 whatsoever. This is a totally different biologic scenario that is linked to ADCs and not to Herceptin or pertuzumab or something like that. So the classical drugs in the early breast cancer are working in classical HER2-positive disease. When you go to metastatic disease, you might need this definition of HER2-low, and you have to reassess the samples. So a HER2-negative disease is not automatically a HER2-low disease. That's a big, big mistake, even if the samples have been analyzed years and years ago. So biology is changing, and if I want to use a new drug which is costly and has side effects, I would like to know if it's really working. So diagnostics is always preceding therapy, even if that's hard to learn, but you have to learn it, that these are totally different ones. This is the new definition for metastatic disease only as we speak. So, and then you have to plan, and we have learned that, the two options of anti-HER2 blockade. You can do a horizontal dual blockade, a monoblockade on the extracellular domain of the HER2 receptor, combining trastuzumab, and pertuzumab. And then you can also have a vertical dual blockade, having an outside modification with HER2, for example, with trastuzumab, and then lapatinib on the intracellular domain, or simply with neratinib, a pan-TKI blocker. So these are various options, but you should not combine both. So you should be very cautious what you're going to do in which sequence, and that is based from a couple of trials. And again, here you see this very simple, the 4 domains of the extracellular domain, and even they have to be functional. So the question is there an anti-HER2 resistance or a loss of function? And I personally think that's a loss of function, because this complex structure is not always perfectly in shape. And the same thing is what you're going to see in the intracellular domain in the TKI subunits. And then you have to decide in which setting you are, which definition you're using, and for which setting you actually have your clinical trials results. So neoadjuvant, adjuvant, and extended adjuvant is a curative situation, and the chronic phase of the disease is what we call metastatic breast cancer. This is not palliative care, what you see in most of the textbooks and publication. This is totally wrong. It's metastatic disease, and palliative therapy is something totally different. So when we just have an idea where we started, 2006, and this is exactly echoing the last presentation, where it's going. So then we have a latest label from China, that will be never used somewhere out of China because there's no production line out of China. So everybody gets his own drug, which is fine when the data are good and the patients receive it. But some authorities then would like to see data if that is comparing to the label we have already. So nobody would actually donate patients in a trial comparing the Chinese drug with other drugs. And why and how did this anti-HER2 treatment in the adjuvant setting was going to start? It was only starting to eliminate micrometastasis. So if you eliminate micrometastasis after surgery, which is the adjuvant setting, you can postpone the time until you have your disease or your metastasis or your relapse reoccurring. And this is a very old graph. These was the classical considerations of the first American trial, chemotherapy followed by trastuzumab, and then the other design was how could you apply it, concurrent or sequential, and the HERA trial in Europe was then different chemotherapies and asking the question at that time, placebo versus 1 year or 2 years. And the data are well known to everyone. It is just 1 year in all the settings, and most preferable, you go for the concomitant treatment to start with the anti-HER treatment as quick as possible. And then over time, and this is what you're going to see here after 10 years, the comparison placebo versus treatment, and there is a totally different in risk of recurrence and the breast cancer mortality. And you can have the same data for ER positive and ER negative because this is the underlying biology of the subgroups. And on the other hand, you see the rate of recurrence in patients if you wait long enough. And the early breast cancer trialist meta-analysis brings you up for 22.9% of recurrences. In the HERA trial, at the 10 years follow-up, 30%. So obviously what you learn out of that, these data are not giving you the best way. At that time, it was only trastuzumab treatment only. Data are different in the affinity trial, but the affinity trial had one problem that was wrongly designed and was only rescued by the addition of node-positive design. So you were just rearranging the cake while it was in the oven, which is totally forbidden. So this was really massaging the subgroups, and therefore I think the data from the affinity trial are not the best data we have, and it turns out after a couple of years it's only active positive effect in the node-positive disease. So if I would design this trial again, I would do it totally different because you have to be aware about the risk of the disease and the risk of the recurrence, and then you can do it. But all these data are not overruling the classical biological factors. So you can see tons of publication where the underlying risk of recurrence based from tumor size, nodal status, biomarkers are just giving us an idea about the risk of recurrence. You know, and the PCA status is just a prognostic information, nothing else. But it's worth doing it, and it shortened the interval. So you see the efficacy within months in a given patient, not in a clinical trial. And I think this is very, very important. So we are doing these guidelines, which are evidence-based, just to make it very easy for doctors to understand how it works. So in small tumors and node-negative disease, as I mentioned this yesterday, surgery is the most preferred option. If you have this situation, then you go as the APT trial from Sarah Laney in the top line. If your surgery proved you wrong or the differences, and you have a node-positive disease, that's the same thing. But if you have a if you have a node negative, it's different. If you have a node positive, then you can adapt your anti-HER2 treatment and your chemotherapy. So you're not harming the patient. Small tumors with a good assessment of the axilla doesn't mean that you have to accelerate your treatment. And when you see those data, this is a very simple design. Most of the people were considering that's a parallel group of treatment. That was just because a slide stops here. Usually the trastuzumab has to be followed on this line. So everyone was considering that's a two-arm trial, but it was not. And if you see now, as I mentioned there in Lancet Oncology 23, the final analysis, it's superimposable. There's no difference. And the curves are just almost, just flat in this. This means there is a low risk of recurrence group within the HER2 positive world, and that is something that I really take for granted. And then let's have a look at the biomarkers which has been brought into this. For the question, is there a hot or a cold milieu? The TILT expression, no difference whatsoever. And then you see some movement in the curves if you see the PAM50 design. You can see that there are, again, different subtypes within the same population. And that is what you can see here easily. The risk score, HER2 positive, luminal proliferation, and all that stuff. So this is, even if this is highly selective, you might need more diagnostic procedures to see if this is really the same tumor that you treat with the same drug. On the other way around, if you see this really clear data, this is research. You don't need it in clinical routine because you cannot do better than a flat line after 10 years. So this is waste of resources. And you can make it very complicated. It looks perfect, makes the expert really an expert on the stage. You can see this from all the different ways. Hormone receptor, PAM50, tumor site grade. So there is a totally different biologic behavior within the HER2 positive disease. And that is a test what Alex Pratt from Spain tried to introduce, the HER2-DX risk score, to give you an idea, if you use it, if you have a more likelihood of a PCR, non-PCR. Again, that is research. I would never ever use it because at the end of the neoadjuvant therapy, the pathologist is giving me the idea, is this a PCR, yes or not? But this is research, and it's a brave approach. So, and I mentioned there's a de-escalation of adjuvant therapy. What can you do? This is the ATTEMPT trial, which is small cancers, almost 490 patients. And they were just randomized to receive TDM1 or only trastuzumab and paclitaxel. You see the data here, small tumors, smaller than 1 centimeter in size, 43, and then from 1 centimeter to 2 centimeters, 57. And what is the result? And if you put this in perspective to the APT trial, you can see the 5 years breast cancer specific survival is 99.4%. This is a small trial. It's not ready for prime time, but this shows that you can play around with the data. I would not start these patients with TDM1, but it's showing that you don't need classic chemotherapy to get to the same amount of treatment. But again, even in India, I guess Sarah Tolani's trial is the best way to get it refinanced. But this is something where we are now, and these are the 5-year analysis. It's a flat line. No risk of recurrence in these patients, regardless of the tumor size and the hormone receptor status, which you see on the far right side. So if we come to an end then, and you see the big tumors and once again, it's core needle biopsy proven positive lymph nodes in the axilla. These are subjects, if the patients agree, for neoadjuvant treatment. Based on the result at surgery, you design your adjuvant or post-neoadjuvant treatment, and we have stressed that enough. The affinity trial, just to show the data, we're asking in 4,800 patients, the question if chemotherapy plus dual blockade is doing better than monotherapy at that time. And you see the data after 8.4 years for the total population, no difference. And then the node-negative cohort, even if the amount of cure is very good, you hardly can see the 4.9 difference in the node-positive disease. So that's a take-home from 4,800 patients with all the logistics, all the money. That's the takeaway from this giant trial. Catherine, different design, asking the same question. We have discussed it. This is a positive trial with 13.7% gain in invasive disease-free survival. This is a trial I would highly appreciate, and it translates in a positive first time ever survival benefit of 4.7%. This is really a very good piece of information. Okay, and then the extended adjuvant treatment. So you have to have a definition to understand what that is. That is then the crosstalk of the ER and HER2 downstream signaling for the TKIs, like neratinib and endocrine treatment. So I'm saying this because the extended trial that this way is only active in the hormone receptor positives. And that was the design of the trial, placebo-controlled, 2,840 patients, and they had various steps of the analysis, 2 years follow-up, 5 years, and then overall survival. So there was a clear-cut definition when they are actually asking the statistician to look into the data. And just in addition to your presentation, the question is, are you looking for trials which are event-driven or time-driven? That's a totally different thing, you know? And here you're going to see the data. After 2 and 5 years, there's a constant, stable benefit in the IDFS analysis of 2.3%. And you can also see that those patients who are in this trial at 5 years and they had no PCR from previous treatment, they have a benefit of 7.4 or 9.1%. So if you have the drug at hand and if the patients are asking you, can I have anything in addition, this would be the only option besides what you should not do, extend the anti-HER2 treatment. And if the patients are standing there, that's a good option to do this for 1 year. And the same thing is, which is very important, I mentioned the overall survival and also the effect of distance disease-free survival, what we would like to see in the adjuvant setting. So this is everything you need to know in the management of HER2-positive disease based on the clinical classic scenario of the histology and clinical parameters. Then you are just looking for your subgroup, your decision on neoadjuvant or adjuvant treatment, and then you're fine and your patients would be very happy to do so. Thank you so much. Any questions? No question? Very good. Thank you.
I would request Dr. D.G. Vijay sir to felicitate our chief guest, Dr. Christian Jackish, please. Sir, one second.
No, put it, that's easier. Get it in my luggage. So it looked like the Oscar, huh? Yeah, thank you so much. This is a good memory. And I was, even if I didn't understand everything yesterday, I was totally impressed by what I can see from the pictures and what I know from the little I know about Indian history, what this guy was doing with all the others. And we discussed it yesterday. There was no internet, of course, no Zoom meeting, nothing. They had really to travel and to make statements. Yeah, absolutely. So
It was very, very impressive. So thank you for your hospitality. Thank you. Yeah, no, it was a pleasure. Okay, thank you.
Thank you.
Thank you. Thank you.
Now I would invite Dr. Vishwajit Pai, who is a medical oncologist at HCG Bengaluru, for the next session.
Good morning, everyone. Today I'm presenting about some of the recent high impact readouts from SABCS 2023. I had the good fortune to attend the Best of SABCS also and selected a couple of papers. I'll be rather very quick. I've been given 30 minutes, but I'll try to finish much before that. So the most important presentation from the SABCS was this, that is the final results of Catherine trial. As we know, since yesterday, a lot has been discussed about the Catherine trial. So patients with HER2 positive cancers who had neoadjuvant chemotherapy with dual or single HER2 blockade, after they underwent a surgery, if they had a residual disease, were randomized to TDM1 versus trastuzumab. The primary endpoints was IDFS and secondary endpoints were DFS and overall survivals, etc. So this is the final results at 8.5 years. TDM1 significantly did better than trastuzumab. As we know, this is based on the in vivo studies where we know if a drug hasn't worked and we've not achieved pathological response, then definitely we need to escalate the treatment. So escalation of treatment has indeed worked well in these patients. The escalation is not only important if there's only dual HER2 blockade or if there's hormone positive. It is very significant in all the subgroups analysis. But if you look at this forest plot, magnitude of benefit is much better when we have smaller tumors or early stage tumors. When we have a T4 or N3, we can make out that the confidence interval is going across the Z line. This is the overall survival with the hazard ratio of 0.66 and a p-value of 0.027. Even the survival is significant with the reduction of death by 34%. Hence, TDM1 fares better than trastuzumab in patients who have significant residual disease. The next paper is called the NEO-N trial. In triple negative breast cancer, we are trying to juggle between the drugs, try to identify various strategies by which we can enhance the pathological complete response, because we know PCR makes it is a surrogate marker for overall survival. So this is a unique study where they tried giving only nivolumab its lead-in in patients with early triple negative breast cancer, followed by nivolumab with paclitaxel carboplatin versus starting nivolumab straight away along with paclitaxel carboplatin. So this the results of this were there was not much statistically significant results. Maybe with other combinations of immunotherapy we might get better results, but this combination where lead-in use of nivolumab did not identify any significantly increased better pathological complete response. The third paper is with regards to the use of axillary radiation or nodal radiation in patients who had early breast cancer and who had neoadjuvant chemotherapy. So patients with T1 to T3 N1, the N1 had to be either confirmed with the fine needle aspiration or a core needle biopsy. And these patients, after completing neoadjuvant chemotherapy, be it hormone positive or a HER2 positive breast cancer, and when a sentinel lymph node biopsy was done, if it was negative, then they were randomized to radiation versus no radiation. This radiation is restricted only to the axilla. If they had a BCS, they would obviously undergo whole breast radiation, but in the presence of a mastectomy, even chest wall radiation also would be emitted. The primary endpoint was local regional recurrences, and overall survival was the secondary endpoint. This study showed that there was no increase in the loco-regional or distant metastasis in patients who had complete response in the nodes, and omission of radiation did not decrease the overall survival. So yesterday we discussed less is more. So I think this is one step ahead where we can omit axillary radiation in patients who had good response to neoadjuvant chemotherapy. Toxicity was also lesser. We can see radiation dermatitis is lesser as compared to nodal radiation. The fourth paper is IM Passion 030 with Alexandra. This is with the use of atezolizumab. Yesterday in the panel I mentioned about atezolizumab not doing very well in the metastatic setting. So this was use of atezolizumab in stage 2, stage 3 triple negative breast cancer as an adjuvant. Okay. So patients who had resected stage 2, stage 3 triple negative breast cancer were randomized to paclitaxel carboplatin, the ACT chemotherapy with or without atezolizumab, followed by atezolizumab maintenance. So this was a randomized phase 3 controlled trial. Surprisingly, the trials was worse. The study had to be declared futile, and the primary endpoint was not reached. In fact, the survival was worse in the atezolizumab combination group. Hence, the trial had to be withdrawn prematurely. The adverse events also were much higher in the atezolizumab, including higher chances of immune-mediated reactions. So again, atezolizumab doesn't do very well in triple negative breast cancer as in the advanced setting. The next important question was in patients with triple negative breast cancer, where we have data for use of olaparib also as maintenance, and also the use of pembrolizumab as maintenance. They have received neoadjuvant chemotherapy. How do we bring about this combination? So this trial specifically looked at this is in the advanced setting. In advanced setting, when they had either an inoperable or a metastatic triple negative breast cancer, patients were randomized initially. They initially received the induction chemotherapy of paclitaxel with pembrolizumab, and then the randomization happened in the maintenance phase when olaparib was added instead of a continuation of pembrolizumab of platinum-based chemotherapy. So this study showed that the number of events was significantly lesser in the olaparib arm, and the survival was not much different in overall group. But when we came across the patients with tumor BRCA mutation detected patients, in that subgroup alone there was an improvement in the overall survival. The median overall survival was 12 months versus 8 months, and the overall survival was not reached versus 23 months. So only in the tumor BRCA mutant patients they were able to demonstrate a benefit with the addition of olaparib as a maintenance along with pembrolizumab. As expected, addition of olaparib does lead to higher chances of hematological side effects, including anemia, neutropenia, and thrombocytopenia. And this is also another important, this is going to come up again in the next couple of years, keynote 756. We have very good convincing data for the use of pembrolizumab in the triple negative, but what about the use of pembrolizumab in a hormone positive setting? So this trial looked at patients who had a hormone positive HER2 negative breast cancer, high risk grade 3, larger tumor, node positive disease, no prior treatment, treatment naive patients who had the regular neoadjuvant phase with acitaxol combined with pembrolizumab, then undergo a surgery. Then again in the end, the adjuvant phase, they receive pembrolizumab along with endocrine therapy, okay, for 6 months duration. The primary endpoint was pathological complete response, and the secondary endpoints were overall survival. So if you look at this, addition of pembrolizumab significantly improves the pathological complete response to about 30% as compared to 18%, more than double even in a hormone positive breast cancer. So this is again PAT-CR in various groups, significantly better. So yeah, so across all groups, pathological complete response was much better. As expected, the immune-mediated events are higher with the use of pembrolizumab, 32% versus 7%, and hypothyroidism was the most common side effect. Thank you for very patient listening. I hope I did not rush through the slides fast. Thank you so much.
Now, we will have a session on case presentation by our residents.
was having dual malignancy, acute lymphoblastic leukemia and carcinoma left breast. Unfortunately, she was expired. She was having complaint of lump in left breast in November 2022. We did core-needle biopsy from left breast, which shows invasive ductal carcinoma grade 2. IHC was showing ER positive, PR positive. HER2 was 2 plus, and it was negative by FISH. We did a genetic report, which was come out to be BRCA1 positive. So this is the clinical details, and we did bilateral sonomammogram and reports, which is here on the display. She had 3 ill-defined irregular marginated soft tissue opacities adjacent to each other in upper outer quadrant. Largest size is 10 into 11 into 7 centimeter, and there is one lymph node, which is 11 into 6 into 10 mm. And we did a PET CT scan. So PET CT scan shows 10 into 16 into 11 mm upper outer quadrant lesion in left breast and left axial lymph node around 10 into 11 mm. And here I rounded the lesion and axillary lymph nodes. So this is the pre-chemotherapy picture. And treatment details, we started patient on neoadjuvant chemotherapy. It was standard dose dense 4-cycle AC followed by 4 cycle of paclitaxel. Her treatment got completed in 15 March 2023, and she was planned for surgery. Response evaluation, we did a PET CT scan, which was showing complete morphological and metabolic response. And here are the representation PET CT image. As we can see, this is the lesion, this is the lesion, this is the lesion, and this is the follow-up PET CT scan, which was showing complete metabolic and morphological response. So at the end of neoadjuvant treatment, as usual, we counsel patient for surgery, but patient refused. So we explained pros and cons and every risk that has to be explained to a patient. Being a BRCA1 positive, BRCA1 carrier, she should undergo mastectomy plus risk-reducing surgeries, and she should be on follow-up, very close follow-up, to rule out any other BRCA-associated malignancies. So post 1 year of treatment completion, she was on tamoxifen, and recently we did a PET scan on her, 22 April 2024, which was showing there is no evidence of disease in primary site or at any distant site. So my question and opinion on this from esteemed teachers would be, how we should proceed for the treatment and follow protocols.
Like Dr. Jackie said, did you do a true cut biopsy from the lymph node?
No, sir, we didn't do.
So we don't know whether it was positive or negative. I think we should start doing it from now on. Try FNAC or core biopsy. Nah, even for metastatic. N2 બી ડોક્યુમેન્ટ કરવાનું એક NCCN ગાઈડલાઈનમાં છે જ ને. ક્લિપિંગ તો is gone. It is a hypothetical concept. ક્લિપિંગ તો કરવાનું જ નહીં. એ જે રાજીવભાઈએ કીધું ને. How do you find the clip? No. No clipping. There is no clear cut. It is a histological diagnosis. It could be a
matted nodes હોય clinically palpable and PET also suggestive that there are multiple nodes which are of without any doubt.
તો FNAC થોડું એનાથી અને follow up PET CT generally we don't do after tumor response. Even a simple ultrasound would have shown that primary has responded, nodes have responded.
But
So there is no
it's,
progression. So we would have probably not done a PET.
Since
But
it's
anyway,
BRCA1 positive, we need to rule out other synchronous other malignancies like ovary or contralateral breast, for that matter.
In this patient, I'm really not sure why the PET was done pre-op. This time it was done for headache. Correct. Yes, yes. Correct. If she had symptoms of neck pain and headache. That is why we had done the PET CT scan for this April. So basically the questions are right now on mammosonogram, I think, and on PET CT scan, there is no evidence of disease morphologically. So A, do we have to offer her any other local therapy other than surgery? For radiation also?
Have we counseled her for undergoing oophorectomy at least?
So that
Yes.
But she doesn't want. But have you counseled her for a unilateral mastectomy or a bilateral mastectomy?
So unilateral for to remove.
Why not a bilateral? She is BRCA positive, no?
Yes, sir.
So arre, suppose she wants surgery. You know, if you send her to me, I will convince her to. Suppose.
we are not counseling her for like we have not done any counseling for.
No, you are the treating doctor right now. She is BRCA positive. So will you tell the patient that the surgeon is going to offer a unilateral mastectomy or a bilateral mastectomy?
So ideally, it should be a bilateral mastectomy to remove the affected breast and to prevent contralateral breast cancer. So it should be.
What are the chances of having contralateral breast cancer in BRCA1 positivity?
Okay. So it's 10% chance of lifetime.
It is, to be precise, it is 3.6, right? So, are you yourself, quite firm that you will offer bilateral mastectomy to each and every patient who's having BRCA1 positivity or even BRCA2?
So since she is 40-year-old and her family is completed by definition that they should have at least 2 living child, so we can offer her. If she is a bit young, then yeah, we can wait on that. At least her family should get completed.
So I think the point that Dr. Tanna is trying to make and Dr. DG is trying, I don't know if you're trying to make the same point or not. But so unilateral mastectomy and then counseling for risk reduction, whichever way, or follow-up screening. So coming back to this patient, now, what are her options? She says, I don't want surgery at all. She will undergo risk reduction salpingo oophorectomy. She's hormone positive. We'll put her on letrozole. So question number 1, A, how do we image this patient going on? How frequently we do images? Secondly, since we have nothing to biopsy, we cannot biopsy to prove whether there is residual disease or not. So imaging, what modalities and how frequently? Secondly, radiation or not? Thirdly, olaparib or not? She does not fit any clinical criteria for inclusion of olaparib adjuvant, but should we give it to her or not? 1 year of olaparib with hormonal therapy.
For imaging, we do 6 monthly MRI and 6 monthly
Like any other
tomosynthesis.
BRCA positive patient.
No, we do imaging twice in a year. Once MRI and the other time we'll do simple rather mammogram or that is what we do. Yes, not more frequently unless she is symptomatic. And radiation, I don't think, because already she is 1 year post treatment. So now.
At that point, would we have offered radiation if the patient did not want to undergo surgery?
Definitely, we should have offered her radiation if she did not agree.
And ma'am, one question I need to ask, since this patient is having no evidence of disease on scan, can we use a liquid biopsy or any such platform, cell-free DNA, ctDNA, to monitor disease progression or any new disease in body?
It is still not there in guideline, but yes, it's a good tool. But then you do need to have a very high concentration of circulating tumor cells to be detected.
The patient has circulating tumor cells. I think the only escalation that you would do to her hormonal therapy is probably to add a PARP inhibitor, right? I don't know what other escalation we would do. So whether or not to add a PARP inhibitor is where I was getting a little bit. I also discussed it with the patient, but I think maybe we can have a little bit more opinions and see what other people would do. The other problem is because she's already 1 year out, now everything is delayed. So she didn't follow up for that 1 year in between. So that is the problem. I think if she had come immediately after, saying that, okay, I don't want surgery and followed up with us, maybe offering her radiation, maybe offering her 1 year of PAP at that point would have made more sense. Now to go ahead and offer her any therapy seems to be challenging.
So I think we should wait.
So I think we just wait, I think is what the consensus is with imaging and then hope for the best. Okay.
She hates us. She loves Mansi. I would have also not done radiation. You, इसको पहले मल्टी सेंट्रिक था, 3 मल्टीफोकल था, पर क्लिप नहीं किया था, पर सब
And it was, and primary tumor size was maximum of 15 mm. So it comes in early breast cancer, maybe T1N1 disease. So there is no role of radiation in early breast cancer if you have done adequate like MRM or other kind of surgery. In these cases, not of what.
is she more likely to die of the index cancer than develop a contralateral breast cancer?
Sir, at this point, it's very difficult to say because she's not fitting in very standard.
N1.
Because now, so she will undergo reflection.
આ જે છે ને risk reducing contralateral mastectomy, very carefully you have to advise because she is more likely to die of the index case than the, and you can, she is 40 years maybe. Then they have salpingo-oophorectomy, so chances of ovarian will go down. Then you put her on letrozole, so chances of contralateral will go down even further. So good for her.
And we have to look for hematological malignancy. Although her mother had ALL, there is no proper case series or something like data which shows that leukemia is inheritable. But since her mother had ALL, so we should have a bit of suspicion to make sure that she didn't have.
But BRCA is associated with ALL?
No, BRCA is not associated. But then, sir, there are many genes which are getting studied.
Maybe.
BRCA. That I did.
Yeah, she had a whole panel then. Now I don't remember. She had a whole panel then. So now for young patients, we're just getting the whole panel done. Okay. So
Thank you.
So at HCG, we are now conducting a small pilot study where we are eliminating surgery as the primary and making ourselves redundant. Any other case?
So what is, so we are starting to do now, we want to do FNACs at least for proving?
તમે કરો છો? તો પેલા જર્મનીએ જ કીધું કે ભાઈ બધાને FNAC કે કોર નેડલ બાયોપ્સી એક્ઝેલામાંથી ભલે N2 ડિઝીઝ હોય પણ પ્રૂવ તો કરવું પડશે. કંટાળી જાય.
If we are not contemplating a post-NSCT sentinel lymph node biopsy for a particular patient with N2-N3 to begin with, then how will it be useful? Doing a biopsy in the pre-hemolytic lymph node. આપણે કરવાનું જ હોય.
I think for N1 disease, maybe we should do.
N1 માં હજી આપણે કંઈક કરીએ.
Because then you can reduce the number of lymph nodes that you are removing.
અને N1 માં we have
And
seen
we are
that
also
many a
proving
times radiological
does not
assessment does not correlate
relate
with
to
the
the pathological
pathological.
assessment.
When N1, if suppose turns out to be N0, then we can go ahead and do a upfront surgery also.
So I think in N1 it makes sense. In N2 and 3, it does not make any sense.
Uh, Good morning, everyone. My name is Dr. Ravi. I am a surgical oncology resident at HCG Cancer Center, Ahmedabad. The case I am presenting is of a 47-year-old female who presented in our OPD with complaint of swelling over left intraclavicular region, which she noticed since the past 3 weeks. There were no other symptoms. Her LMP was 6 months back. Obstetric history, 2 live births, both full-term deliveries. Medical comorbidity, she was hypothyroid on regular Eltroxin 50 microgram daily. There's no contributory family history, no significant family history. Other history, she had carcinoma left breast 3 years back, treated outside. She underwent left modified radical mastectomy. Her final HPE report after the surgery was IDC NOS grade 3. It was a triple negative disease. The staging was PT2N0. Size of the primary was 2.5 by 2 by 1.5 centimeter. And it was negative for DCIS or LVI. She also underwent adjuvant treatment at the same center. She underwent 4 cycles of AC and 4 cycles of Placlate XL and was disease free up until she presented in our OPD. On examination, there was a 3 by 2 centimeter hard consistency fixed swelling over the medial infraclavicular region, just lateral to the sternal border, in the region of the first intercostal space. Over the previous mastectomy scar was appreciable over the chest wall. There was no evidence of any other swelling on the chest wall or on the left axilla. Right breast and axilla were normal on clinical examination. Bilateral supraclavicular region, there was no evidence of any fullness or swelling. Systemic examination was normal. She had also undergone an ultrasound for the same, which was suggestive of 3.3 by 2 by 3 by 2.3 centimeter lesion, possibly malignant. That was the comment on the ultrasound. She underwent a ultrasound guided core needle biopsy, which was again suggestive of an IDC NOS grade 3 lesion, and IHC was again triple negative over the left side chest wall swelling. She underwent a PET CT for a metastatic workup, which was suggestive of a hypermetabolic necrotic deposit involving the intercostal muscles of medial aspect of left first intercostal space, extending just anterior to the first intercostal cartilage. There was focal involvement of deeper fibers of pectoralis major in the area of the swelling, and the lesion was mildly bulging into the extrapleural space. However, there was no pleural invasion. There was no underlying bone erosion, lung parenchymal involvement, or mediastinal involvement, and there were no distant metastasis on PET. This is the representative image of the PET. In the arrow, we can see the lesion. The question arises in this being a case of a local recurrence and being again a TNBC lesion, what should be the further plan of management? Based on the recent guideline, we should, what I could come across was that we should, if the local recurrence is surgically resectable, we should undergo a the patient should undergo surgical resection. As already AL&D has occurred, there should be no repeat axillary lymph node dissection done on the area. And then repeat RT if feasible, and then adjuvant systemic therapy again. Yes, sir. Yes, sir.
Is very notorious to have systemic disease, but
Yes.
once it has remained at the local site, that definitely means that the previous surgery was partly incomplete,
Yes.
and that is why this has occurred. If it was quite an aggressive disease, then it would have metastasized by now. Going deep down into the muscle fiber, that shows you the nature of this tumor to be locally aggressive. So you need a good local treatment itself. Thereafter, if required, then you can boost it with RT and put the patient on capecitabine. But comparing to neoadjuvant local would be preferable because the nature of
Yes,
the
sir.
tumor itself is looking like it is locally aggressive, this thing. And it is the remains of the previous surgery.
Yes, sir. And it probably would be feasible at this stage since there is no bone erosion, so we would not.
બોન ઇરોઝન તો હશે જ ને. આમાં પેટ સીટીનો રિપોર્ટ ક્યાં ગયો?
In other words, if you give NACT and that this thing responds completely, then what will you do? Will you offer surgery or will you not offer surgery? If you do offer surgery, then how much will you remove?
So I'm not sure, but if the we'll keep her on follow up if the patient is undergoing neoadjuvant, and if we see that the lesion is regressing.
હું તને શું કહું
હા,
છું કે patient previously also had received complete 8 cycles of AC followed by Peckley, right?
Yes.
If this would have been, if this is a local recurrence and probably a residual of the previous one,
Yes.
એ રહી ગયું હોત તો it would have responded to the adjuvant line of AC followed by Peckley and it wouldn't have recurred. Now, if you put this patient on NACT, patient achieves good complete response, and then you wait again after 3 years, you will see this, and probably, I mean, more aggressive than current one.
એટલે this was seen by me and seen by some medical oncologists. And then senior medical oncologist said, we will again give 6 or 8 cycles of chemo and then radiate. And that will be enough because it probably looks like a soft tissue recurrence. એટલે કદાચ બોની નહીં હોય. वो अपने जो बोल रहे थे तुम. No. This is not the location for the internal memory node. So we are planning to operate on.
What I want to say is, if chemotherapy was to work, it would have worked by now and wouldn't have led to a local recurrence. Because of the previous AC followed by Peckley. That is the whole crux. If you give neoadjuvant and if you want to omit surgery, then it should be a complete response, which it was.
First surgery was outside.
Surgery was T2 and 0, right?
થીક ફ્લેપ્સ છે એટલે કદાચ થોડું બ્રેસ્ટ ટિશ્યુ રહી ગયું હશે અપર ઇનર ક્વોડ્રન્ટમાં. ત્યાં લોકલ રિકરન્સ થયું છે.
This is a classic example that you cannot omit surgery in this setting after neoadjuvant. In this case, adjuvant, if it would have worked, then the lady shouldn't have had recurrence. Only caveat is that patient did not undergo radiation because of stage did not warrant. And what is the morbidity of resecting out this thing? What is the morbidity of resecting out?
Surgery, radiation, chemo.
Surgery, radiation, chemo.
What was the initial systemic therapy that you I think we do Paclitaxel carbo, right? We'll do Paclitaxel carbo.
Petma it was 3 centimeter. Petma also it was 3 centimeter.
So you basically if it's locoregional recurrence, and if you're resecting and doing everything, you're still treating her with a curative intent, right?
Yes,
So
ma'am.
then only capecitabine I don't think is enough.
Three years, ma'am.
But he responds well, then the question is how much will you excise?
I think if it's operable, better to operate. It makes things more complicated once you give new engines.
Guidelines also say that if it is resectable without significant morbidity, go ahead. Look at some picture. It is sizable, quite far away from India and all that.
Sternum. Touch करो.
Yes, sir.
पहले sternum ना काटो. Sternum काटी ना.
ના ફ્લેપ્સ ઠીક છે બતાય
આ બાજુ સિટી વાળા પિક્ચરમાં
એટલે MRM જ થયેલું છે.
પહેલા આ જ ક્વાડ્રન્ટમાં પહેલાનું ખબર નહીં
ના પહેલાનું they did not have the documents of previous mammography. Pre treatmentનું તે લોકો પાસે નહોતું કઈ documentation. They just had the chemotherapy documents. Yes, sir, because she is 47 years old. If a TNBC case is less than 65, we should go for BRCA testing. And yes, sir. Yes.
So we have two cases in the last 2 years where patients have been diagnosed with pregnancy. Patient did not know, but because when you ask LMP and it's at least more than 1 month, then before starting any treatment, one was metastatic and one was I think pre-treatment, like any treatment. So
stage 3, I guess, but came with 3 mammograms, came to the criteria and went through. हमारे 10 દિવસ પહેલાની હિસ્ટ્રી આપી છે when we ત્યાંથી ફોન આવ્યો that one. चलो अभी कहीं है तो consensus is to operate
chemo radiation, genetic testing.
Yes, sir. Thank you.
Thank you. Full time. Jump back.
હવે શું કરશું તને ભાઈ
હવે માણસ ઘણો છે અને કેટલા શું છે આપણે
हाँ पुष्पेंद्र भाई करे.
હા
પાસ સ્ટુડન્ટ બસ હતી એમના એક્સપિરિયન્સ જાણીતું નથી એમણે હમણાં કોઈ રિસન્ટલી
ગાડી લઈને
અચ્છા ને બેલનો અવાજ આવે છે
અચ્છા એસી ના લીધે अपने पास गाड़ियां हैं दोपहर को जाने के लिए तो निकल जाए खाना खा के अहमदाबाद
મંગાવી લો ને તો નીકળી જવાય. હું તો નીકળું જ છું પણ તમારી
શું કેમ નીકળે?
હું રસવાળા સાથે જઈશ પાછી. આ ટ્રેન હું શું કરું? ચોકડા એના કરતાં બીજી જગ્યાએ મંગાવી દો. છેક ટ્રેનમાં 8 વાગે તમે રાતના 12 વાગે પહોંચો ત્યારે તો કામ તો કરવાનું પાછું. શું લે? અને 40 ડિગ્રીમાં આનો કરવાની છે.
ત્યાં જઈએ. આપણે કેટલા લોકો છીએ? 1, 2, 3, 4. એક છે ને સિદ્ધાર્થ પાસે ગાડી છે. ગાડી લઈને આવ્યો છે. ત્યાં કોઈ ગાડી કોણ આવ્યો છે? આની વાઈફ એટલે 2, 3, 4, 5, 6. આની વાઈફ 7, 8, 9, 10, 11, 12, 13, 14. 19 મેડમ 22, રાજેશ શર્મા 23, કાજલ 24. How many cars will need? 4?
5.
नहीं बस वो टिकट अपन कैंसिल कर सकते हैं. हाँ. तो दोपहर को लंच लेके निकल जाए, स्टैच्यू कर दे तो निकल जाए. ये जरा बराबर नीट एटलीस्ट बट 5 कार પેલા જગદીશ વાળાને બી કહીને રાખ્યું છે આ પ્રકાર.
Presentation.
એનું શું કરવું? ચલો
Good morning, sir. Good morning, faculty. I am presenting one case, young female with bilateral synchronous primary. 45-year-old premenopausal female presented to us with history of painless right breast lump since 2 years, which gradually increased in size since last 3 to 4 weeks with mild pain and discomfort. She didn't have any comorbidities, no non-drug allergy, but had a strong family history of malignancy. Her 2 paternal aunt had a malignancy, first as breast malignancy at age of 45 year and contralateral breast malignancy at age 70 year. Her second paternal aunt had a ovarian malignancy at age 55 year. Her paternal uncle also had probably esophageal malignancy at age 60. She is gravida 2, para 2, with 2 live births and both full-term normal delivery, adequately breastfed both child. Last delivery was 16 years back. She is a premenopausal with regular menstruations. Her bilateral sonomammogram suggestive of basically 3 lesions. One was in the retroareal and central quadrant. Maximum was 2.2 centimeter. Another lesion with skin thickening and nipple retraction. 2 another small lesion were there in both are like T1 and BI-RADS category 5. There was 16 into 13 mm suspicious right axillary node, BI-RADS 5, and on left breast upper outer quadrant there is one 9 into 7 mm lesion with spiculated margin, BI-RADS 4C. So biopsy was done from right breast. It was an invasive mammary carcinoma with lobular growth pattern and TNBC. Left breast, it is IDC, ER positive 10%, PR HER2 negative. Her PET CT was done for staging workup, and there were total 3 lesions in the right breast. First largest was 20 into 17 into 15 mm, which was in the retroareolar and central quadrant. With overlaid skin thickening and nipple areolar retraction. 2 to 3 enlarged low-grade FDGA with nodes in the right axilla, which was favor metastasis. Largest was 16 to 13 mm. And there was non-FDGA with lesion 8 into 7 mm in the upper outer quadrant of left breast, possibly synchronous second primary. She didn't have any distant mets or left axillary or internal memory or supracritical nodes. So she was referred to genetic counselor in view of bilateral synchronous primary with strong family history. Her comprehensive hereditary cancer gene panel by NGS plus MLPA was done, which suggestive of BRCA1 VUS from Strand Diagnostic, which was reported as benign as per CleanWare. So,
But you did do FNSC from the node.
We
That when you were
Question
sitting
when,
as a
can you go
delegate,
back?
you say, I will do node biopsy for N1.
So
Now
it-
when you become faculty, you say, I will not do.
so sorry, sir. It was learning. It was in the past. We will do then.
What you learn on a conference in Sunday that you will implement on the Monday.
So I think
कल
for
से
this,
FNSC का राफड़ा.
Jignesh bhai कैसे के बीजा? So I think for this patient, we should also do FNAC from the supraclavicular node if possible.
Ma'am, it
because
was very small size.
But still 14 by 8. So
14
if
into
it
8
is
mm.
possible, we should do it from the supraclavicular. I think supraclavicular nodes, we should really start doing a lot more FNACs than what we normally do. Yeah.
Recently, yes.
So I think going back in this patient, we should, if we have a similar case again, we should do FNAC from the node, both axillary and the
And supraclavicular.
supraclavicular, right?
Right. So now the clinical dilemma was with strong family history and bilateral synchronous breast malignancy. But BRCA1 was VUS on genetic testing. Question was to repeat the genetic test from another lab. Whether to consider it as a BRCA1 mutant, and treat accordingly in clinical context. And what will be the surgical treatment options in that case, and whether it will alter the surgical approach as well as the adjuvant treatment.
So from a surgery, so in terms of neoadjuvant chemotherapy, it would be standard AC paclicarbo with
yeah.
give carboplatin to this patient because she has all clinical features of being a BRCA1 positive despite the genetic testing, and of course TNBC. So in surgery, from a surgery standpoint, anything? AC paclicarbo. Dose then?
Yes.
We give dose then to everyone.
So then, yeah. So this is her further update. She was planned for neoadjuvant systemic therapy. Her pre-chemotherapy workup was normal. In view of TNBC stage 3 right breast cancer, we also offered neoadjuvant immunotherapy, but because of some reasons, she couldn't opt. She received 4-cycle dose-dense EC and interval USG, so regression in the right breast lesion and static left breast lesion. She was planned for then weekly paclicarbo for 12 cycles. She developed grade 3 neutropenia and thrombocytopenia at 8th and 9th cycle, which required growth factor support, both romiplostim and filgrastim, and then further dose modifications were done. Omission of carboplatin was done in the last 2 cycles. Then she underwent surgery, left mastectomy with left sentinel lymph node biopsy, right MRM with axillary lymph node dissection. Her histopathology report was left breast, no residual invasive carcinoma, no involved nodes. So it is TPCR, total pathological complete response. In right breast, it is RCB class 2, RCB score 3.2, YPT1 C and 1 stage 2B. Left was static. It was
positive,
yeah,
right?
10%.
10%.
It was
And right was TNBC.
TNBC. And interval USG left was static, right was showing regression. But in final histopath, left is complete response. It was 8 into 7 mm on imaging.
Mastectomy from a
Left side.
left mastectomy was offered from a prophylactic perspective, patient preference or any? No, I know, no, I mean, sorry. So no BCS.
No point of doing BCS on one side and mastectomy on the other.
Okay. So from a cosmetic perspective.
BRCA borderline. So then better to do bilateral mastectomy if you are very advanced than bilateral reconstruction. Yeah.
So, sir, in these cases, we counsel patient for reconstruction at the time of surgery, or we prefer it to be a staged procedure, or what is the counseling for reconstruction?
Immediate is always best. Nobody comes back for a delayed reconstruction. So,
Another part is, ma'am, if we have done a left-sided BCS, she would have a bilateral breast irradiation, and that would be too morbid because it is if early stage, and delivering the both and firing lung is a difficult task.
he refused for immunotherapy because we told her about immune cardiomyopathy, which we learned in that batch.
2%.
भी आएगा ना, Pembro का,
2.5.
then we will tell them, scare them. CT scan बताया तो ये तो गजब होता नहीं आप क्यों रिएक्शन आ ILD का होता है this lady developed second malignancy sometimes later on, then how would you have differentiated whether it's metastatic disease from the primary one or a new one?
So, first thing we'll do the biopsy. We will do the ERPR HER2 Ki67, though definitely it's not the confirmatory. First thing. Second thing, as far as I know, I don't have any answer that will definitely tell you whether it is a second primary or metastasis, even in the molecular side also. Ma'am, you can correct me if I'm wrong.
कितने आएंगे ये लोगों की पर जो there is one criteria was given by an Indian author called Chaudhary way back in 1984. So they say that when you take biopsy from the current malignancy, and it shows that there is some in situ carcinoma, so then
Background.
it's a second primary.
Second primary.
Because you cannot have a metastatic in situ
In
disease.
situ
In
disease.
situ disease is always a new occur.
Right.
Then if the histology is different,
Then
also it is a new
different.
primary. Again, if histology is not different, but the newer tumor is of higher grade, then also consider it as a second primary. And the third one is, last one is, at the same time, if there are evidences of, loco-regional recurrence at the primary malignancy site or some distant metastasis, then it should be considered as a met from the opposite side.
Right. So then she completed adjuvant radiotherapy, hypofractionated course. Then she completed 6 cycles of adjuvant capecitabine because there was a residual disease on the right side, TNBC, till March 2024. And as she was for left breast ER positive, we started on hormonal therapy and OFS plus tamoxifen, and we are planning to switch on the OFS plus AI on the next follow-up. So this was the case.
Tell her to repeat the genetic test from some other lab.
So we did not do a supraclavicular mode biopsy in this case. That was, probably I would say, it was a problem. You have radiated the supraclavicular.
Yeah.
Then we now onward we make a note that
It should.
whatever the supraclavicular node is, we
Thank you.
So in the CREATE-X trial, they are allowed for capecitabine to be started concurrently or after radiation is complete. So you can give it with radiation also, no problem. We usually start after radiation just to let the patient get over all the chemo side effects. And then sometimes with radiation, patients have fatigue and this ordinophagia and dysphagia. So we started after radiation, but technically you can do either. Who is recheck? Because we don't. No, but that is very confusing. So we don't. No, but the Ki67 and tumor receptor तो अलग चीज है ना? तो TNVC में KS67 का क्या काम? It's all still research. It's not ready for prime time. So we don't do.
You are unmarried.